Vanakkam. When a diagnosis of obstetric palsy or birth brachial plexus palsy is made, the first logical question from the parents would be, will it become normal? We need to answer this question based on scientific evidences. And if we say that surgery will be required, the response will be, Doctor, the movements have improved since birth. Is surgery necessary? And this question too needs a scientific answer and explanation. And to know how to derive at these answers, follow this video carefully as it takes you step by step through the process of decision making in birth brachial plexus palsy in infants. If a child with birth brachial plexus palsy has been seen very early or even at the time it was born, the sequence of events is as follows. This child needs a monthly follow-up and then a decision needs to be taken, and this decision is going to be whether the child needs surgery or will the healing be complete on its own. The decision that is made at this stage, that is when the child is still an infant, is different from the decision that needs to be taken when the child with a birth brachial plexus palsy grows up. This is because the surgical management in the neonate and infant is mainly primary nerve surgery on the brachial plexus, and the surgical management in the grown-up child is mainly treatment of the sequelae and residual deficits. This video is going to concentrate on this aspect, that is the decision making in the neonate and infant with birth brachial plexus palsy and the indications for primary surgery of the brachial plexus in these infants. When we look at the overall modalities of management available for these infants, therapy plays an important role apart from primary surgery of the brachial plexus and Botox, which also plays a very limited role. The questions that we need to answer when treating an infant with birth brachial plexus palsy are: what modality of treatment should I choose? In which of these infants and neonates should we plan a surgical management? And if I am going to plan a surgical management, when should I carry out this surgery? And what surgery should I plan? We shall be answering the first three questions in this episode. But before we go into the nitty-gritty, let us brush up three important things: the Naraka's classification, the MRC grading of muscle power, and the active muscle scale or the Toronto scale, because these are going to help us in decision making. Details of these can be found in the previous videos. Under the Naraka's classification, type 1 refers to upper plexus injury, the classical Erb's palsy, where the roots C5 and 6 alone are involved. This can be identified because the hand will have normal movements with wrist extension. Type 2 is the extended upper plexus injury or extended Erb's palsy, where C7 involvement is there along with C5 and C6 roots. This can be identified in that the hand will have normal movements but there will be no wrist extension. Type 3 is characterized by total palsy with no Horner syndrome. The hand and upper limb will be flail. Here all the roots are involved, C5, 6, 7, 8 and T1. And in type 4 too, all the roots are involved, but here there will be typically a Horner syndrome. Medical Research Council system of muscle grading. When there is no contraction, it is grade 0. When there is a flicker of contraction, it is grade 1. If there is active motion with gravity eliminated, it's grade 2. If there is active motion against gravity, it is grade 3. Active motion against gravity and resistance is grade 4 and full power is grade 5. To make the assessment of this muscle power more quantifiable, the active movement scale was developed at the Hospital for Sick Children by Curtis and Clark. When gravity is eliminated, if there is no contraction, the score is 0. If there is contraction but no motion, it is 1. If there is less than 50% of motion, the score is 2. If there is more than 50% of motion, the score is 3. And if there is full motion, the score is 4. When the movement is tested against gravity, if there is less than 50% of motion, the score is 5. If there is more than 50% of motion, the score is 6. And full motion against gravity gives it a score of 7. When we consider the indications for surgical management, all cases of types 3 and 4 of Naraka's classification at or around 3 months of age must undergo surgical management in the form of microneural surgery to get meaningful recovery of hand function. In this waiting period of 3 months, these infants may show some recovery in the shoulder, elbow and hand, but they will not result in useful hand function. Decision making becomes a little more difficult in type 1 and type 2 Naraka's classification, where some infants will need surgery. So the decision making here must be scientific. In Naraka's type 1 and 2, some children may have an excellent recovery, some may not have a good recovery. These infants with excellent recovery do not need surgery. If we operate on these infants, we may interfere with the recovery. Of those infants who progress but show poor or incomplete recovery, if we don't operate on these infants, we may be losing a good opportunity to get a functioning upper limb. Now, two questions arise. 1. How do we predict which infant is going to have an excellent recovery or a poor recovery? And secondly, how do we decide whether the incomplete recovery needs surgery or not? Before making an algorithm of decision making, let us see some studies that have been done in this regard, that is decision making, to understand the problems better. In a landmark thesis by Tassin in 1983, it was generally agreed that a lack of anti-gravity biceps function at 3 months is an indication for surgery in C5-6 plus or minus C7 lesions. The logic behind this is that the biceps is the only C5-C6 innervated muscle whose function cannot be duplicated by other muscles and therefore is a good indicator of C5-C6 recovery. Clark and his group around 94-95 used the scoring, that is the AMS scoring, and were prepared to wait for a much longer observation period to come to a decision. They also used the cookie test around 8 to 9 months in children who are on the borderline of surgery and conservative management to make a final call regarding the indication of surgery. This system is a little more cumbersome. Waters, in a review in 2005, summarized this issue. He concluded that infants who recover partial anti-gravity upper trunk muscle strength in the first 2 months of life should have a full and complete recovery over the first 1 to 2 years of life. Infants who do not recover anti-gravity bicep strength by 5 to 6 months of life should have microsurgical reconstruction of the brachial plexus, as successful surgery will result in a better outcome than natural history alone. He also concluded that infants with partial recovery of C5, C6 and C7 anti-gravity strength during months 3 to 6 of life will have permanent progressive limitations of motion and strength, and they are also at a risk for the development of joint contractures in the affected limb. In this regard, the correlation of microsurgical reconstruction with outcomes was studied in upper brachial plexus and extended upper brachial plexus palsy by Gilbert and Tassin in 1984. In C5-6 lesions that were not operated on, there was a 100% class 3 recovery according to the Mallet score. You will remember that class 0 represents no function and class 5 represents full function. He also found that C5-6 lesions who had microsurgical management, that is, primary repair of the brachial plexus, had only 37% with class 3 recovery, whereas 63% showed class 4 recovery. Similarly, in C5, 6, 7 lesions that were not operated on, 30% had class 2 recovery and 70% had class 3 recovery. But following microsurgical reconstruction in such lesions, that is C5, 6, 7 lesions, 35% had class 2 recovery, 42% had class 3 recovery, whereas 22% had class 4 recovery. So the results were demonstrated to be much better following microsurgical management in C5-6 and C5-6-7 lesions. The results of primary microsurgical reconstruction appeared to be good. But what happened after the secondary reconstructions were done as the child kept growing? Gilbey and Whitaker addressed this issue in 1991 when they studied the results at 2-year follow-up and again at 5 years after performance of secondary shoulder reconstructions. Their study found that after primary reconstruction of the brachial plexus in C5-C6 lesions, 81% had class 3, 4 or 5 Mallet score results at 2-year follow-up. In a pan palsy, 25% had class 3 and 4 shoulder function, 70% had class 3, 4 or 5 elbow function, and 35% had class 3 or 4 hand function. After secondary surgery on the shoulder, in a 5-year follow-up they found in upper brachial plexus lesions, 70% had class 4 or 5 results and no class 3 results. In global palsy lesions too, 77% had class 4 or 5 shoulder function and 75% had class 4 or 5 hand function. Gilbey maintains that microsurgery not only improves function in selected patients over what would be expected from the natural history, but also increases the possibilities for good results after secondary tendon transfers. Like microsurgery, secondary shoulder tendon transfers and osteotomies also play a role in significantly improving function in patients with residual deficits. In a subgroup of 20 patients with shoulder reconstructions, there was a significant improvement for all Mallet classes. Clearly, patients with no biceps function by 6 months or a Toronto score less than 3.5 have poor prognosis and will benefit from microsurgical reconstruction of the plexus. But how different are patients who undergo microsurgery at 3 months from those who recover biceps function between 3 and 6 months and undergo secondary reconstructions? So, for infants recovering biceps between 3 and 6 months, should we do microsurgery or wait and do the secondary reconstruction later? To bring about a clearer understanding of the results of primary management of birth brachial plexus palsy, a meta-analysis in 2015 showed the following results. This study was a pooled analysis of 222 patients from 9 cohort studies. All the studies showed that nerve repair reduces impairment. The relative risk RR is 0.58. The relative risk or the risk ratio is the ratio of the risk of an event in one group, example the exposed group, versus the risk of the event in the other group, that is in the non-exposed group. 95% CI or confidence interval was between 0.43 to 0.79. The confidence interval displays the probability that a parameter will fall between a pair of values around the mean. The p-value is significant and less than 0.001 and the absolute risk reduction is 19%. Absolute risk reduction ARR represents the proportion of patients who are spared the adverse outcome as a result of having received the experimental rather than the control therapy. In a review article by Thatte et al. From India in 2011, they have used Gilbert's criteria along with MRC grading. If a child with upper plexus lesion does not have biceps function exceeding MRC grade 3, that is anti-gravity movement, at 3 months of age, then surgery is recommended. If there is visible biceps contraction but triceps co-contraction preventing elbow flexion is present, or biceps being 2 plus but not really 3, etc., we can wait and watch with or without Botox to the triceps up to 6 months, by which time the picture gets clearer. If biceps continues to be under MRC grade 3, then surgery is definitely better than the conservative treatment. To make this easier to understand, let us see an algorithm for the decision making in birth brachial plexus palsy. For Narakas type 1 and 2, if we see the infant very early, we can make a clinical assessment and then advise therapy. We can perform an electrodiagnostic study at 1 month, which is a good indicator of prognosis. In this study, we may note innervation of the biceps muscle or no evidence of innervation. If the biceps innervation is noted at 1 month, the chance of good spontaneous recovery is better. The biceps is the only exclusive C5-C6 innervated muscle whose action of elbow flexion and supination cannot be replicated. Whether innervation of the biceps is noted or not, the child is followed up with therapy till a clinical assessment at 3 months. At 3 months, a complete clinical assessment of the child is again made, and we particularly look for power of the biceps, whether it is anti-gravity power or grade 3 according to the MRC classification. We may find grade 3 biceps contraction or no anti-gravity biceps contraction. If grade 3 biceps contraction is noted at 3 months, no primary surgery of the brachial plexus will be required, as studies have shown these patients will progress to good functional recovery of the shoulder, elbow and hand. If there is no anti-gravity biceps contraction at 3 months, we need to look for whether biceps contraction is seen or felt. The compound motor action potentials of the biceps and triceps can be compared with that of the opposite normal side, and clinical and electrodiagnostic evidence of triceps co-contraction should be looked for. The biceps contraction may be very poor or not felt at all, or it may be felt well, though not up to grade 3. If it is poorly felt, a decision can be made to perform primary surgery on the brachial plexus in these children based on the scientific studies that we have seen so far. But when the biceps contraction is felt well, or the compound motor action potentials of the biceps is comparable to that of the opposite side, we can continue therapy and reassess the biceps power at 6 months. We can make a decision for surgical management if there is still no anti-gravity biceps power at the end of 6 months. But if anti-gravity power of the biceps has been established by now, we can continue therapy. We also need to follow up these children to look for secondary deformities developing in the shoulder or elbow. If there is clinical and electrodiagnostic evidence of triceps co-contraction, Botox has a role to play, and this is discussed later in this video. So far, we have been discussing elaborately on the modality of surgery of the nerves for birth brachial plexus palsy. But we should also consider the other modalities, that is, the role of therapy and the role of Botox. Therapy has an important role right from the day the diagnosis of birth brachial plexus palsy has been made. This therapy must be started early, and parental mobilization of the limb is key. Gentle mobilization of all the joints of the affected limbs must be done. There are 5 sets of exercises to be done by the mother during each breastfeeding session. Shoulder circumduction exercises to get full range of the shoulder motion and to relax the co-contracting adductors and internal rotators. At one point, the mother can feel the shoulder relaxing completely after initial resistance. External rotation exercises of the shoulder with the arm adducted and elbow flexed. Hand to mouth and elbow extension exercises, pronosupination exercises with the elbow flexed, and fingers and wrist mobilization. Of these exercises, the shoulder circumduction exercise should always be done first in order to make the affected side relax and thereby to avoid any unpleasant experience by the baby during external rotation. Each exercise is generally advised to be done with 10 repetitions, and in case of the external rotation exercise, to hold the final position to a count of 5. This protocol is continued till breastfeeding is on. The supervision of the therapist regarding the method in which the exercises should be done is very important. Botox too has a small role to play in the infant with birth brachial plexus palsy. It can be used when there are co-contractions between the triceps and the biceps. In this condition, Botox can be injected into the triceps and the correct power of the biceps can be assessed. If the power is good enough, there may be no need for surgery. Finally, we shall discuss the role of surgery on the nerves of the plexus in the infant with birth brachial plexus palsy. When we plan for a primary surgery in such a situation, what surgery will we be planning? It will be one of the following 3: nerve coaptation or primary nerve suturing, nerve grafting, or nerve transfers. We can understand the concepts and need for primary nerve suturing and nerve grafting in birth brachial plexus palsy. But what is the role of nerve transfers? Can we do distal nerve transfers as described by Oberlin and Somsack? As you may recall, Oberlin had described a fascicle from the intact ulnar nerve to the biceps and a fascicle from the intact median nerve to the brachialis can be used to provide elbow flexion, and the branch to the long head of triceps can be transferred to the axillary nerve to provide neurotization for the deltoid. The advantages would be the speed of neurotization and that the existing movements are not lost because we will not be excising the neuroma in the plexus. Also, in C5-6 lesions, that is upper brachial plexus palsy or Erb's palsy, triple transfer can be used to reconstruct shoulder abduction, external rotation and elbow flexion. In C5-6-7 lesions, intercostal nerves can be used for the deltoid and intraplexal neurotization to the C7 posterior division of triceps and wrist extension can be done. An article by Thate and Mehta says that distal nerve transfers have the benefit of targeting select muscles with no visible function, and this can be done without cutting the neuroma. These transfers can be used for late referrals where some movements are seen and these are not lost even temporarily due to a resection of the neuroma. Gilbert and Raimondi, in a study done in 2011, showed that classical reinnervation was better and distal nerve transfers can be reserved for later use as they provide rapid innervation. But there is no conclusive evidence to show that distal transfers give better results compared to classical neurotization. We have planned surgery, but when is it to be carried out? It depends on when we see the patient first. If we see the child only at 4 months, we cannot immediately jump into surgery. But if the child has been seen since birth, surgery can be planned at 3 months. Surgery at 6 months is also good because it gives time for the parents to accept the decision, and also the anesthesia becomes a little safer. There is a little disadvantage in operating at 6 months because of the psychological factor. By this time, some amount of movements do occur and the parents will always feel that some improvement seems to be there. Should we operate, doctor? So, as far as the surgical management, that is the primary surgical management in birth brachial plexus palsy is concerned, we have now taken a decision to do a plexus reconstruction of the nerves. But what strategy do we follow? That is, what do we do if the roots are available? What do we do if the roots have been avulsed? We are going in to do a surgery for a child with upper plexus lesion, that is Erb's palsy involving C5 and C6 roots. These roots may both be available or both roots might have been avulsed. What do we do? The complete strategy that we can follow will be discussed in the next video. I hope you liked the video. I enjoyed making it. Please do click on the shown links to see more about clinical features in birth brachial plexus palsy and the different investigations that can be done in this condition. And do not forget to subscribe to stay connected with the latest in learning hand surgery, plastic surgery, trauma surgery and ethics. Vanakkam.